Is Yahya Ithawi, and I'm a pediatrician neonatologist. And today our talk is about apnea of prematurity, and I selected the topic based on requests from some of our colleagues. The objectives for today is to define and give some introduction, and we'll talk about periodic breathing and some background about time of and late preterm apneas. We'll talk about pathogenesis and respiratory drive and mechanism. And then we'll go to management, including general and methylxanthines and its discussion, like its efficacy, use as prophylaxis and indication, discontinuation, side effect, and some topics around it. And then we'll end the discussion talking about discharge planning. So what's apnea? Apnea means cessation of respiratory airflow. However, there is sometimes short pauses of breathing, which takes about 5 to 10 seconds. So again, apnea is cessation of airflow. There's short pauses, which is 5 to 10 seconds. Apnea of prematurity is defined as apnea, cessation of breathing more than 20 seconds, or shorter respiratory pauses, mean less than 20 seconds, but associated with desaturation and decrease in heart rate. And when you say apnea of prematurity, we're talking about babies born less than 37 weeks at delivery. However, apnea of infancy is defined, same definition, but in babies born at equal or more than 37 weeks at delivery. Apneas are 3 types: central, obstructive, and mixed. How we differentiate? We're basing on 2 factors: respiratory effort and the flow. So you have respiratory effort, but you don't have flow of your upper airway due to upper airway obstruction, then it's obstructive apnea. You don't have flow, but you don't have respiratory effort, so you are central apnea. So the definition of central, obstructive, or mixed, both of them is depend on continued inspiratory effort and presence or absence of airway obstruction that causes no air movement. Central apnea, again, absence of respiratory effort. Obstructive apnea, there is an inspiratory effort, but it's ineffective. There is no movement of air due to upper airway obstruction. Mixed apnea starts by upper airway obstruction and with absence of inspiratory effort. Most of apneas in preterm babies are central or mixed. And the percentages of different type of apnea are 40% are central, 50% are mixed, and only 11% are obstructive. The longer, the more mixed is the apnea. Shorter pauses or periodicity, and usually central. Apnea of prematurity increases with decreased gestational age. Periodic breathing is a pattern of rapid breathing alternate with respiratory pauses. This cycle usually repeats itself every 5 to 10 seconds. Sometimes you have a little bit of dips in saturation, and sometimes you have decrease in heart rate, but I won't define it as bradycardia. These periodic breathing are very common in premature babies. How to differentiate it are very short, alternating, only dips, but no definite desaturation, decreased heart rate, but there is no definite brady, and usually they don't need interference. Apneas in term baby are very rare and very infrequent. However, whenever they occur in babies, they are pathological. They are never central. There should be a pathology. They are not like apnea of prematurity. They are not due to immaturity. When you have apnea in a term baby, take it serious. Look for the causes. Most common causes is seizure, infection, asphyxia, hemorrhage, stroke, or NAS, neonatal absence scoring, either withdrawing and seizure or depression from mom taking medication, or sometimes is obstructive airway. Most common cause of infection that causes apnea in term babies is RSV infection, also sepsis and other infection. In late preterm, however, it's not that common, but it's not as rare as in term baby, not as common as in babies less than 33 weeks. Persistent apnea is the apnea that associates with longer hospitalization. NICU definition of apnea varies, and therefore incidence varies. Each NICU uses its own diagnostic criteria for apnea. But in general, the incidence is underestimated because we define apnea, usually we depend on nursing report. We put on a criteria for the nurse and nurse report. And most of the nurses, for various reasons, they underreport. Or they underestimate the event and therefore they don't report it. So they underreport, but also they underestimate. And this has been confirmed with ongoing cardiorespiratory monitor. So if you go back over the last 24 hours and you look on your cardiorespiratory, you find lots of apneic events or periodic breathing, but it's not being reported by the nurse. And therefore, most of NICU depend on nursing reporting in an apnea sheet, and therefore the incidence usually is underestimated. Apnea of prematurity almost occur in all babies less than 28 weeks. Most of babies less than 28 weeks, their apnea will continue until mid-term age. And usually they need prolonged hospitalization. Usually the apnea completely resolve, we're talking about apnea of prematurity, between 43 to 44 corrected gestational age. So apnea of prematurity is different from term apnea. Term apnea is pathological. However, apnea of prematurity is due to physiological immaturity. It's not a pathological process. And the reason why, because in fetal life, there is placenta help exchange, while breathing are intermittent. And there should be a switch from intrauterine to extrauterine, from intermittent breathing pattern to continuous breathing pattern. We don't know what caused this switch. So if that switch does not happen, then you get apnea of prematurity. Again, we don't know the reason why this switch is not happening. So when you disrupt this transition process due to immaturity, you get apnea of prematurity. And this interruption, it might be due to interruption of respiratory drive centrally, or it might be due to inability of premature baby to maintain the patency of the airways. The central respiratory drive initiated by different triggering factors, by the level of the CO2, by the level of O2, and by pH changes. And also respiratory drive get input neuronal and chemical. Again, respiratory drive by changes in CO2, O2, and pH, and got pulses, got messages from neuronal and chemical receptors. The premature baby is immature. The central chemosensitivity is immature. And that immaturity decreased the peripheral chemosensitivity. And also immaturity of the inhibitory pulmonary neuronal signals. Examples: respiratory drive affected by hypercapnia or increased CO2. The increment of CO2 primarily sensed by the brainstem, with smaller contribution from peripheral chemoreceptors in the carotid and from carotid and aortic body. However, in preterm infant, the response or the ventilatory response, the centrally driven ventilatory response to high CO2 is immature, blunted, or failed. And therefore, when you get CO2 high, we should breathe fast. Because the response are blunted, they stop breathing. When you have a premature baby and you have high CO2 and they have apnea, this gets furtherly decrease in the response, the central response on high CO2. But remember, the central depression or central inappropriate response that led to decreased ventilation or decreased ventilatory response in a premature baby is centrally mediated, has nothing to do with the pulmonary mechanics. So even if you ventilate the baby still will have apnea. The other driven factor for the respiratory drive is oxygen. When you have hypoxia, obviously we should have better ventilation. I mean, when we say ventilation, we don't need the rate, but better volume, better PEEP. And this happens through sensing the oxygen level by a receptor at the carotid body and further area in the chest, send it centrally, and then the sense that oxygen is going down, then we need to improve the ventilation. When you have hypoxia, on the other hand, in premature baby, you have biphasic response. First, the response to decreased oxygen sensed by peripheral receptors is increased ventilation, hyperventilation. Subsequently, the ventilation drops, and then they cause apnea. So CO2, there should be hyperventilation. Premature baby response is apnea, decreased oxygenation, the response hyperventilation, and then apnea. The biphasic response not only occurs in a premature baby and late preterm, it also occurs in early term babies at 37 and 38 weeks. And therefore, sometimes when you have 37 weeks and you don't find causes, some people might try caffeine because they think it might have an element of apnea of prematurity. But that should be your last resource. Term baby is pathological. Sometimes this biphasic response to apnea can persist into adult life in some people. And the best way to feel this response when you go on high mountain and when you get low oxygen and high CO2, and then you'll see your response, how your body will react. The other factor, so we talked about high CO2, we talked about low oxygen, hyperbilirubinemia. Some people and some data suggest that increasing level of bilirubin in a premature might cause apnea. We don't know the reason, but might be due to the bilirubin cross the brain and affect the brain function. And therefore it affects the brainstem response to increasing CO2 and low oxygen. Other factor affecting respiratory is the patency of upper airway. Because remember that you can have inspiratory drive, but you should have patent upper airway. There are many factors affecting the patency of upper airway in premature babies, like poor pharyngeal muscle tone, absence of reflexes, nasal obstruction, laryngeal edema. And I'm not going to go to the details of that because that would be not on my purpose of the study. But here's, you have a collapse of upper airway and the pharynx due to prematurity. Same in hypopharynx, you can have poor tone, but also you can have some edema, especially when the child sleeps. And therefore, apneas sometimes occur more during night when the child sleeps, and then you need to awake the child or the kids or the premature baby. Nasal obstruction, obviously, from excessive suction, from prolonged CPAP, from prolonged use of feeding tube can cause also apneas, because as I know, you know that neonates are obligate or preferentially nose breather. Larynx and trachea can cause laryngeal edema, vocal cord improper function, tracheal stenosis, whether acquired or inherited or congenital, tracheomalacia or laryngomalacia, all can affect the respiratory drive. How apnea present? The first scenario of apnea is the apnea evident in a spontaneously breathing baby that been never giving ventilatory support occur in first few days of life. So no respiratory support, all of a sudden in first 3 days of life, the baby stop breathing. The second one, or the second way of presenting, is breathing pauses with dropping heart rate and desaturation. Remember, most of the apnea are central, and therefore, even if you are having ETT and mechanical ventilation, you still have apnea. So if your respiratory support are just baseline, even with that, sometimes you get desaturation and decreased heart rate because of apnea. However, sometimes same events can occur due to cardiorespiratory reflex response to presence of an airway and tube, a foreign material in the upper airway. The natural history of this presentation in premature babies is toward increasing frequency of these events in the second and third week of life. Usually, the apnea of prematurity resolved by term at 37-week corrected gestational age if in babies more than 28 weeks. For those born less than 20 weeks, usually it persists up to 43 weeks corrected gestational age. The frequency of apnea of prematurity in babies 43 corrected gestational age, it's exactly the same frequency of apnea occur in preterm, late preterm, and healthy term babies. So if you have a 24-weekers, and now he is correctedly 43 weeks corrected gestational age, the incidence of having apnea at that corrected age, it's exactly the same of a patient now 43 weeks, but he was born at term. Remember, apnea of prematurity is one causes of apnea. It's not the whole. This is the most common, it's a physiological, it's immaturity, but there are other causes. Especially sepsis. It's very important to remember that sepsis can cause apnea. And the most common scenario is you didn't have you did not have apnea after birth, and then all of a sudden at week 1 or like second week or third week, you start to have apnea. It's a new apnea. It didn't happen in the first few days of life. So you have to think. And at that point, you need a thorough evaluation of either the sole cause of apnea, or might be other precipitating factors or increasing factors toward the apnea of prematurity. So you might have apnea of prematurity aggravated by these factors, or these factors might be absolute cause of apnea other than apnea of prematurity. How we diagnose apnea? Apnea, no respiratory effort, respiratory pause more than 20 seconds. Might be shorter, but with desaturation and brady. And remember that if you are less than 28 weeks, almost all babies got apnea. If you are less than 28 weeks, 50% of them got apnea. However, all preterm babies should be monitored for occurrence of apnea. We diagnose apnea of prematurity by exclusion, especially if the apnea did not start at birth or first few days of life, or it's a new event, or sudden change of the apneic events. How we monitor apnea? We use a respiration monitor. Neonatal cardiorespiratory monitor utilize the impedance technology. And impedance, as you know, it's measure the movement, the motion of the chest. And because it affects the chest motion, therefore, as you remember, you might have chest motion, but you don't have flow of air in the upper airway. So still you have chest movement, but you don't have flow due to obstruction. So the monitor that uses the impedance technology will not diagnose it. So it only effective in diagnosis when there is no movement of chest, when there is no inspiratory effort, when it's a central, and sometimes when it's mixed. Because in obstructive, you have continuous inspiratory effort, but you don't have airflow. And therefore, we use other tools, which is the monitoring of saturation using pulse oximeter. And remember, pulse oximeter measures the percentage of oxygen attached to hemoglobin, the saturation. But also, it calculates the heart rate. And because it measures the brady, which is the response to the apnea, and oxygen level, which is the drop of oxygen due to apnea, then it can diagnose both the central and obstructive apnea. And usually the monitors, the SAT monitors set to diagnose apnea more than 15 seconds to give alarm for the nurse to report and respond. Heart rate also is a part of apnea of prematurity, either at time when it's a short pause or as a complication when it's prolonged. Because heart rate usually drop when you have low oxygen due to apnea. And many centers, including our centers, we set the heart rate to give the alarm when it's less than 80 pulse. But sometimes the patient is sick, if we are escalating the management, if we're not doing anything, we can go down to 70. If the brady is occasional, usually you have no side effect. However, these alarms limit has no evidence. It's just a way to practice. Pulse oximetry is an adjunct to monitor. We cannot put the baby only on sat monitor. You have to have respiratory monitor, because respiratory monitor use the impedance, not the oxygen saturation. So you should have pulse oximetry for saturation, you should have respiratory alarm, and you should have a cardiac alarm. Short respiratory pauses, what you will do with them. They give you an idea about low lung volume due to residual lung disease or due to pliable chest wall. There is very important factors when you use the pulse oximetry, what we call it sampling time, which is the time interval between two readings. So the sampling time can be every 1 second, every 2 seconds, every 5 seconds, every 10 seconds. The longer the interval of that sampling time gives you more peace of mind, because it will not show you the pauses, the short pauses of desaturation. However, there is some evidence, and people are studying this, that they use what we call it cumulative desaturation time. So they use tachogram, and it tells you how long over a period of time you were under that saturation level. So each time is 1 second, 2 seconds, 3 seconds, over 24 hours. Like you might get 1 minute of desaturation, and whether that has a later on consequences or not. But the longer the sampling time, the less you will get the false alarm, and also alarm about short pauses and desaturation. What is the differential diagnosis? Many. The most common is the physiological apnea of prematurity. There are other factors, especially environmental. Patient is hot due to environment, whether excess bundling or abnormal incubator temperature or whatever. Also, giving magnesium sulfate to the mom to protect the brain of the baby is depressing. Using opiate as an analgesia for mother. Using opiate as an analgesia and sedation for the baby. Bleeding, stroke, and neonatal encephalopathy can cause apnea. Upper airway problems, different type. Hypoxemia from different reasons can cause apnea. Anemia. Different metabolic disorder. Necrotizing enterocolitis. Seizure can present as apnea. How we manage apnea? The first goal is to differentiate the physiological apnea of prematurity from pathological apnea. And then start by evaluation of maternal neonatal history. As we said, magnesium sulfate, opiate in both baby and mom. Looking at factors and risk factor for sepsis, trauma and IVH and asphyxia. Infant of diabetic mother can have pathological apnea. Signs of other etiology, like signs of hypoglycemia, signs of sepsis, sign and symptom of neurological impairment, signs of upper airway problem, and signs of neck. All can cause apnea and need to be looked after when you want to exclude other causes of apnea. Very important is the feeding, because feeding associated with some respiratory and cardiac change in the baseline reading. Like change in color and change in heart rate, tachycardia and bradycardia can occur with babies up to 34 to 36 postmenstrual age. And this reason is abnormal deglutition, or what we call it the coordination between sucking, swallowing, and breathing. And this disturbance of the basic baselines, respiratory and cardiac vital signs can continue up to 38 weeks corrected gestational age. Also, when the baby starts to breathe or to feed, there might be a ventilation issue, and then drop of the oxygen. And as we know, hypoxia is a cause of apnea in premature babies. What we do when the nurse called me that there is a baby with apnea? In addition to the history that we ask for, we'll ask for CBC. We ask for blood culture. We ask for glucose. We do blood gas. And we do metabolic. If we have a metabolic, we do metabolic screen. We ask for head ultrasound sometimes. How we manage? First, we should have apnea alarm or apnea report. And we report apneas, or we should report any baby desaturation below level of 85. Or we also should report any babies who need positive pressure ventilation. Or when the baby has clusters of events. Although also we report babies who has respiratory pauses more than 20 seconds without desaturation. When we start treatment, the treatment usually needed for several weeks until the patient or the baby is fully in control of his respiratory system. The goal of the management or the measure is to decrease apnea and decrease its complications of hypoxia. So we can use CPAP, we use Methylxanthine medications, and sometimes we use non-invasive ventilation, and sometimes it reaches to a point we have to intubate and start mechanical ventilation. The general measure is more sort of preventive than treatment. And most babies less than 35 weeks will need these measures. With also general measure, we are trying to eliminate all the risk factors that increases the apnea and decreases the hypoxic events. How we monitor? Because remember we said change in temperature can cause apnea, both hyperthermia and hypothermia. So we use servo control radiant warmer or incubator that is connected to the environment inside the incubator, and also it's connected to the service temperature of the baby, and automatically control the environment temperature to keep the temperature of the environment of the incubator within normal acceptable limit. However, there is a problem with that, because when the patient gets infected and get hyperthermia or get cooled, the incubator will change the temperature. So when the patient hyperthermic, the incubator temperature goes down. So whenever there is changes of 0.5 degree Celsius in the incubator, the patient needs to be checked. So that's one factor. And also hypothermia can cause for zillion reasons. So when the patient is hypothermic, the temperature goes up of the incubator. And therefore, always when you have temperature changes more than 0.5, you need to check their evidence of neonatal sepsis or environmental problem. The patient is being warmed by, for example, excessive bundlings, excessive clothing. And remember, swinging of temperature of the incubator up and down due to change in temperature of the baby is also one sign of sepsis. Head position is very important to put the position, and we in our unit practice putting the baby in midline for 3 days, and we even don't weigh the baby. to keep the baby in a comfort position. And the purpose is decrease the IVH, not to decrease the incidence of apnea, but it can help too, because remember, flexion and extension, both of them is a precipitating factor for upper airway obstruction, and upper airway obstruction is one type of apnea, we call it obstructive apnea. Very important to maintain the nasal patency, whether there is suctioning, switching the nearest for nasogastric feeding, when we apply CPAP, all that you need to make sure that the nose are patent. We need to give oxygen, we need to maintain the saturation. There are two targets, low target, high target. Both of them has benefit and has side effect. 88 to 92 associated with less ROP, but associated with high mortality. 90 to 94 associated with less mortality, but high ROP. So the target of oxygen saturation need to be discussed and maintained. And also, always oxygen needed to keep the baseline oxygen level in acceptable limit. We might need to give non-invasive ventilation like CPAP or advanced CPAP or bi-level CPAP, and we might need to give non-invasive ventilation. But also we might need to also ventilate at some point. The other is methylxanthine therapy, because it stimulates the respiratory and neuronal input by inhibiting the adenosine receptors. There are two types that we use, is caffeine and theophylline. Caffeine is always preferred, longer half-life, wider margin of safety, less side effect, but of course is more expensive. There is very clear evidence that when you start caffeine, the apnea is less. CAP study show no difference in using caffeine in rate of death or abnormal head ultrasound or incidence of NEC. Caffeine associated with decreased need for PDA ligation, bronchopulmonary dysplasia, also associated with earlier discharge home, less need for oxygen supplement at home, decreased duration of ventilation, and decrease also the incidence of going home without need of CPAP, or decrease the incidence of or shortening the duration of CPAP. Also is another, with use of caffeine, is another indication that caffeine is treating apnea. A reduction of PPD by using caffeine suggests that this medication is a good tool or weapon to treat this problem. But there is no clear difference at 2 years neurodevelopmental assessment from using caffeine. However, other long-term benefit cannot be excluded. Caffeine decrease the risk of developmental coordination disorder. We use prophylactic, not only treatment when you have apnea, but we use it as prophylaxis because it seems that it decreases the incidence of intubation and mechanical ventilation due to apnea. However, the study is very limited regarding the benefit of prophylactic caffeine in premature babies. Canadian network, neonatal network, they study the difference between early administration of caffeine in the first 2 days of life and administration in late after 3 days of life. And in this study, or in this comparison, because it's a data entry, 75% of babies were giving early in the first few days of life and 25% giving late. And it showed that early caffeine group has lower risk of the composite outcome, the combined outcome of death and bronchopulmonary dysplasia. So it's less death and bronchopulmonary dysplasia in early group. And most of the effect is not death, it's due to PPD, because the difference in mortality are not that big. Also, the early group are less likely to develop PDA and need for ligation. There are no difference between early and late regarding neck, neurological injury, and ORP. Therefore, the prophylaxis uses of caffeine gaining momentum, and almost all the wards start caffeine as early as possible. The methylxanthine is a competitive inhibitor of adenosine receptor. And adenosine is inhibitory neuromodulator of the respiratory drive that we were talking about. So when you give caffeine, it blocks the adenosine receptors and it increases the ventilatory response to CO2, which is one of the factors that we talked about apnea. Also revert the central hypoxic depression of breathing due to low oxygen. It increased the diaphragmatic contraction, improve the pharyngeal muscle tone, and therefore decrease the incidence of upper airway cause of apnea. And it's also, when you give the caffeine, the respiratory neural output start to improve within 5 minutes of IV loading dose. And also it increased the cerebral cortical activity, and it decreased transcutaneous oxygen monitor. If you guys listen to my lecture or watch my presentation about respiratory monitor, you will understand that. It also increases the mean arterial pressure. Caffeine may also decrease the effect of hypoxia on perinatal white matter, and also inhibit pro and anti-inflammatory mechanism, because it's adenosine, most of the pro and anti-inflammatory are adenosine receptor subtype mediator. What's the side effect? Cause feeding intolerance, cause tachycardia. More severe, it can even cause abnormal movement and contraction and other problem. However, the side effect is much less than theophylline. Theophylline can cause gastroesophageal reflux due to a delay in gastric emptying. Also, the caffeine increased metabolic rate, so you might have improper growth. Also, it can decrease the blood flow to the bowels and may be associated with feeding intolerance. Which one you use? Caffeine or theophylline? Caffeine has a longer half-life, so you can give it as a single dose, while it's a very frequent dose for theophylline. Enteral absorption are very predictable in caffeine and not predictable in theophylline. Therefore, the therapeutic index are very wide in caffeine and very short in theophylline. Caffeine measurement usually is not needed unless you go very, very high dose, like 40 or 50 milligram, which nobody goes. And therefore, if you use the normal dose, you have very high margin of safety, you have no absorption variability, and therefore you don't need measure. However, there is no difference between theophylline and caffeine in reduction of rate of apnea and bradycardia in first week of life. But the side effects are much less in caffeine. What's the indication of using it? Is any apnea that is reported, such as apnea more than 20 seconds, frequent, apnea that need prevention, or apnea that cause desaturation and apnea that need cluster and need intervention. How we initiate? We give loading dose. It depends whether you have caffeine citrate or caffeine base. So you give 10 or 20 or 10 milligram per kg per dose. You can give loading dose IV or oral. Maintenance same can be IV and oral. It's 24 hours after the loading dose. And again, it depends whether you have caffeine straight or a caffeine base. So you give 5 to 10 or 2.5 to 5. I usually like to start with 2.5 caffeine base, because that's when the baby develops, as a prophylactic, baby develop apnea. I can give mini load Instead of 20, I give 10, and then I increase that to 2.5. And if no response, I can give after 24 hours to another load, and I increase to 7.5. So I usually like to start 2.5. And sometimes to avoid ventilation, I go up to high doses of maintenance. Sometimes I go up to 8 and divide it to 2 doses to minimize the side effect. Steady state usually reach after 1 week. The therapeutic is very wide range, therapeutic level 5 to 25 milligram per liter. And there is no difference between the level and the response. So then the level not need to be, and the side effect is low and safety margin, you need to give like 80 milligram per kg to get toxicity. So it's really very wide range of safety, and therefore you don't need to measure level. When to discontinue? No data. Most of us previously, we were discontinuing at 32, 34 weeks when the baby is free of apnea for 5 to 10 days, 5 to 7 days. If you deseed the caffeine today, then you need to keep the baby in the hospital for 7 days to record there is no apnea before sending. Otherwise, if you want to send the baby home prior this time, you should keep the baby on caffeine and then reevaluate after 1 month of discharge. So most people are discontinuing the caffeine at 33 weeks when there is apnea free for 7 days. However, sometimes you need to use it for a prolonged time, especially for babies who was born in less than 28 weeks. Cardiorespiratory monitor should be continued after deseeing the caffeine. Very rarely you need to reinstate caffeine, but you should if you have a frequent episode, you have brady or desat, or you need to intervene with apnea after you discontinue the caffeine. Who's failing? Infant failing when you give caffeine and then you need to give CPAP or non-invasive ventilation or even ventilation. Do we need to transfuse for apnea? Very hard to answer. It depends on the frequency and severity of apnea. But it's documented that transfusion decreases the frequency of apnea. Now, is this related to correct anemia, or it's better perfusion, or improving the volume? We don't know. But there is a study in very small babies, when you give transfusion, there is decreased rate of apnea. What is the rule? We don't know. But there is a study, I don't want to go to details to that report that the apnea is later, but it again depends on how to define apnea. So they define it when the shot less than 80 or more than 4 seconds or less than 3 minutes. But transfusion has no effect on the frequency severity of hypoxemia in babies less than 7 days of age. When to transfuse? I don't know, it depends. A ventilated baby is different from non-ventilated baby. Babies on weight, gestation, how sick, oral feeding, non-oral feeding, all that contribute to when to transfuse. What is the lower oxygen? What is the side effect? What is the situation? The presence of lines? All that. It's very hard. We should individualize each case. Persistent apnea usually occur in babies born less than 28 weeks gestational age, and it might continue to 37 to 40 corrected gestational age. But when you have still apnea after 40 weeks, I would call this is persistent apnea, and I might deal with it as a pathological apnea. But some babies, even with physiological apnea of prematurity, they might not be ready to go home at that age, but though they are not pathological apnea. Control of breathing almost always gained by the age of 44 corrected gestational age. The plethysmography, the 2 channels or more than that, plethysmography used to assess apnea of prematurity, especially during sleep. And this is used when the baby have persistent apnea more than 40 weeks and still need caffeine, and then we need to know whether this is central, peripheral, central or obstructive peripheral, or it's a mix. And then this is a study is very good in predicting which baby will get severe cardiopulmonary events, or also it's a predictor of SIDS syndrome. We use the multi-channel comprehensive physiological recording, and it measures the respiratory airflow, the inspiratory effort. Also, it measures the gastroesophageal reflux, and it also assesses the sleep state, rapid eye movement or non-rapid eye movement. And it helps to differentiate between central obstructive apnea, mixed apnea, and also give you an idea if there is a seizure. How to send home? The baby should be free of apnea, of caffeine for 1 week. Use of monitor at home, not advisable. Sometimes a mild apnea and ready to go home, the best would be if the baby is not in apnea, not on caffeine, clinically no significant apnea. Home. If has apnea, then no home. If it's in between, mild apnea, pauses, no bradydischarge, it's very hard to decide. I would do it on individual cases. Sometimes I send home if they are within the city, if they are close to the hospital, if they are educated. Sometimes I don't send. Whether these short, mild respiratory pauses are important, I don't know. Maybe have some prognostic factors. I would give 7 to 5 days without caffeine before I send home. Otherwise, if they want to send home and it's urgent, I would keep the baby on caffeine. Again, as the criteria is different, but that would be my go on it. Sometimes we send the baby on cardiorespiratory monitor. And when you put the baby on cardio monitor, it can be with or without caffeine. Now, it's very difficult to send baby at the evidence of it are very weak, but the whole idea is when you put the monitor, you need to discover the parent to see if there is apnea or not. If they discover the apnea, then they need to deal with it. So they need to, how to manage the monitor, how to know this is an artifact, how to provide stimulation, and if the baby stops breathing, then how to provide cardiorespiratory resuscitation. Without these 3 points, there is no point of using cardiorespiratory monitor. Almost always that the cardiorespiratory monitor can be discontinued at age of 44-week corrected gestational age. And I'm done, and I'm open for questions, and thank you for listening.